number of speakers today. Before we get underway, and I'll let Dr. Schwab announce the topics and some of the idea behind what we're talking about today. But the first things first is we want to thank the Seattle Science Foundation for their support in this effort. This is something that we've jointly done with the NAS, the North American Spine Society group, the spinal oncology group from there, and a number of us are members of that, and that's why we really feel this is an important joint opportunity. And the second group we'd like to thank is Icotech, which is a company that makes spinal implants specifically for spinal tumor patients. And so they've graciously and generously supported this so that we could bring this to you. So with that, I'll hand it over to Dr. Joseph Schwab, who can introduce some of the speakers today and the topic. And then I will, and Joe will ask questions as the day goes on. Thank you.
Thanks so much, Dan. I'll introduce Sam Cho and Ajit Krishnani, who will introduce the topic themselves. Welcome, guys.
All right, welcome everyone. Cleveland Clinic is very, very excited to host this month's Spine Oncology debates. And thank you to both Dr. Shuba and Dr. Schwab, as they both mentioned. Today we have Dr. Samuel Chow, who is the Vice Chair of Quality and Safety for Radiation Oncology here at the clinic. He's also Director of CNS Radiation Oncology and the Associate Director of Gamma Knife Center. And then on the flip side, we have Dr. Ajit Krishnani, who is the Vice Chair of Neurosurgery, and he is also a specialist in spine tumors here at the clinic. We're going to start off today with Dr. Samuel Chow, who's going to give us his perspective on the management of recurrent spine metastases. Dr. Chow.
Yeah, no, thank you very much, and thank you for the opportunity to present at this forum. I'm looking forward to it. So in terms of recurrent metastases, certainly there is a tremendous role for radiation. Historically speaking, when we only had one tool, which was conventional radiation, we really were limited to salvaging these patients with either chemotherapy or surgery. Since the advent of stereotactic radiosurgery or stereotactic body radiation therapy for the spine, about a couple decades ago, it's been a real game changer in terms of how we manage recurrent tumors, in the sense that we often salvage patients with who previously received prior radiation with spine stereotactic radiosurgery, and in fact even use spine stereotactic radiosurgery as an upfront treatment to manage recurrent disease. As long as there's about 6 months separation from the prior radiation, typically speaking, it's always something that we think about in terms of retreating patients with either repeat radiosurgery or radiosurgery to salvage patients who had conventional radiation previously. There are things that we want to focus on in terms of who makes the best candidates for re-irradiation. So those are patients who really have good separation of the tumor from the cord. They don't really have a lot of fractures or instability within the spine that does require surgical fixation to manage that. Certainly patients with more radiosensitive disease are going to be apt to have better control with re-irradiation as opposed to surgery. Certainly patients with a lot more compression of the spinal cord, or even the Bilski grade of 1C or more, where it's abutting the spinal cord, we may even want to think about doing something like separation surgery before we introduce repeat radiosurgery. But there's plenty of options in terms of radiosurgery as a good salvage option for management of recurrent spine disease.
So Dr. Chow, talk to us about what does the re-radiation look like for a patient who's been previously treated for EBRT versus previously treated, which is standard radiation therapy, versus someone who's previously treated with SBRT. So what does that re-radiation look like in radiosensitive tumors versus what does re-irradiation look like in patients who have quote-unquote radio-resistant tumors?
Mm-hmm. So there's a lot of things that we think about in terms of re-irradiation. So as I mentioned earlier, we like to have 6 months of separation from prior radiation, and part of that is to allow for adequate cord recovery. So if someone had previous external beam radiation, conventional radiation to that area of the spine, we typically even think about single fraction radiosurgery. Some folks like to do fractionated radiosurgery. However you do the radiosurgery, it's a matter of just trying to get the dose in and making sure that you are able to spare the spinal cord. When it comes time to do repeat radiosurgery, meaning that the patients had previous radiosurgery, we start to kind of think things a little bit differently from a radiation standpoint. In that situation, we actually like to fractionate the radiosurgery a bit more. So the folks at Sunnybrook really had done some elegant studies looking at their own experience with repeat radiosurgery. And so a patient had previous maybe single fraction or 2-fraction radiosurgery, or maybe even 3-fraction radiosurgery. Sometimes we even think about doing 4-fraction radiosurgery to salvage those patients. Again, we want to have about 6 months separation from the prior radiosurgery. As far as radio-resistant disease versus radio-sensitive disease, sometimes we even think about trying to dose escalate a little bit more by fractionation. So, for example, when we looked at our own series of patients who had single fraction radiosurgery for more radio-resistant disease. So I'm talking about things like chordomas, metastatic chordomas, sarcomas, for instance. When we looked at single fraction radiosurgery, because of the modest dose that we can only give with single fraction radiosurgery, the outcomes were not as good as if we did 3-fraction radiosurgery to a total dose of 30 gray. So sometimes we do think about fractionation as a matter of trying to get more dose for radio-resistant disease.
So if a patient's received prior EBRT, then they're going to receive 1 or 2 fractions of SBRT. And if a patient has received prior SBRT, which is SRS, then the recurrent radiation or the second time radiation is going to look like a hyperfractionated radiosurgery, correct?
Correct. So we're going to give like 4-fraction radiosurgery to a total dose of 30 gray as our standard option for re-irradiation.
That's fascinating. So in patients who have radiosensitive tumors then, and we're treating recurrent Mets with radiosurgery, then the paradigm changes. For example, a tumor that would traditionally just melt away with EBRT now comes back, let's say breast cancer, for example, and now we're going to treat with some kind of hypofractionated radiosurgery. And in that case, in those patients who have cord compression, we can't just melt away the tumor with radiation. So now in these recurrent Mets, the paradigm changes for the treatment of radiosensitive tumors, meaning that requires some type of separation surgery for a radiosensitive tumor, correct?
Sometimes we do have to think about that, because what happens when we do radiosurgery, we have to really limit the core dose. And so when we're trying to limit the core dose to maybe a maximum dose of 14 gray, that's really on the edge of being able to give enough radiation dose to the epidural disease. So disease, like, for example, Bilski grade 1C, where it's abutting the spinal cord, maybe not necessarily deforming the spinal cord and not necessarily cord compression, may be actually difficult to actually get a sufficient dose to really maximize control. Anytime we have significant epidural disease, we have to think about that the local control may be, maybe knocked down by even 10% or 20%, just by the virtue of having epidural disease that we're not able to get sufficient radiation dose to.
So if the patient who has a prior radiosensitive tumor has recurrent cancer with cord compression, we're treating with radiosurgery, then would we even say that cancer is radiosensitive anymore? Has the biology of that cancer changed that would deem that tumor more radioresistant?
And that's a good point. Sometimes when we do radiation, we probably maybe select for radio-resistant clonogens that have allowed to recur. There's a lot of different diseases that we have looked at over the years, even like small cell lung cancer, where we've done radiation and then they become a little bit more resistant to radiation. Their local control rate isn't as good. So we do have to think about that, in terms of involving surgery as a paradigm to really maximize local control.
And are you involving the oncologists in the plan for radiation, changing the treatment options, the cytotoxic agents, immunomodulators?
We always think about the oncologists. I mean, the oncologists do play a role in some diseases. For example, lymphomas obviously are going to be maximized, with something like chemotherapy, and certainly we would give them the first opportunity to do that rather than considering radiation. But at the same time, a lot of different therapies could potentially influence either local control or increased toxicities, for instance. In many of the cases, and we've looked at this in our own institution, that, for example, TKIs could actually augment, if given concurrently with radiation or radiosurgery, increase the rate of tumor control. So certainly we don't necessarily want to stop systemic therapies just because we're going to do something from a radiation standpoint. There are certain drugs that could potentially even augment or improve local control. Another example of an agent that can improve local control when given concurrently would be immunotherapies. So, when we're doing immunotherapies and we're treating the tumor, we're releasing antigens, we're allowing the T cells to recognize these tumors a little bit better, these tumor antigens, then you can actually potentially even get better local control that way.
So it sounds like we're treating the majority of recurrent metastases with radiation, or excuse me, with radiosurgery. Are there any other newer and more innovative radiation treatment paradigms for recurrent tumor or spine metastases?
Yeah, and people have looked at, brachytherapy, for instance, as a means to control disease that have seen a lot of radiation in the past. The folks in Memorial Sloan Kettering have been pioneers about that. There are other things that we think about, maybe not necessarily radiation, but thinking of things like cryotherapy or radiofrequency ablation that could also potentially help.
That's fascinating. All right, well, thank you, Dr. Chow, for those insightful comments. And I'd like to bring in Dr. Krishnani into the conversation now. So, Dr. Krishnani, it sounds like the treatment from a radiation perspective for recurrent spine mets is actually radiosurgery. How is that changing your surgical management?
Well, I mean, I think that's Sam brings up a lot of great points, and I work with Sam a lot here at the clinic, and so we've really kind of developed together and grown over the last 20 years together. And I think that the way we think about recurrent metastatic disease has changed dramatically from the time I started my career 20 years ago to now. I think the advent of radiosurgery and really being able to do recurrent tumors with radiosurgery has really changed the way I think about surgery as an adjunct for this, and that really becomes what it is. It's no longer the primary treatment for these recurrent tumors. It's more an adjunct to how we can better deliver the radiation to really control these recurrent mets. Sam talked about epidural disease, and that's really the main focus of what we're looking at, along with stability. So from my perspective, as a surgeon, I'm looking to see how stable is the spine, structure of the spine, how much bony destruction is there something we need to do to stabilize the spine, either because there's a fracture there or there's an impending fracture there, to prevent further complications down the road. And number two, are they going to be able to dose in the recurrent tumor enough to get control? And what I mean by that is that epidural disease, do they have to decrease the dose to protect the cord? Or is there a way we can go in there and do some separation surgery so they can give an effective dose to the margin of the tumor to prevent that marginal recurrences? Sam will tell you many of the recurrences we find is along that marginal zone in the epidural space. And that seems to be the area that we're most vulnerable to in terms of recurrence. And a lot of that has to do with the dosing of the radiation, that they just can't dose that medial part of the tumor near the cord as highly as they can the parts of the tumor further away. And that makes that the most likely site of recurrence. We also took a look at some of our studies, and it seems to be the edges of the radiation field seem to be other prime areas of recurrence, kind of going along with that dose de-escalation along the edge of the targeting that seems to be the prime location for these recurrences. So I'm really focused in on that. When we see a recurrent tumor, do they have enough space to effectively dose the recurrence, or do we need to kind of give them some more space away from the cord and do a separation surgery for them? And like I said, the other part of that is the stability. Do we need to do some sort of instrumentation to prevent that? The flip side of that is with the increasing dose of radiation, that increases the osteoporosis of that bone as well, making it higher risk for fracture. And so we're a little bit more aggressive with these recurrences about stabilizing than we might be with a primary met, because we know that's already been dosed once with radiation. We're coming back with another dose. That bone is not going to be nearly as strong as it once was, and maybe more prone to pathologic compression fracture down the road.
So if in a patient who's had prior radiosensitive tumors, I know at the Cleveland Clinic, we're pretty aggressive with the radiation. We just treat those with EBRT, standard conventional radiation. However, if that tumor were to come back and we're planning on treating with SBRT, then that previously radiosensitive tumor would require separation surgery now, correct?
Potentially, yeah. I mean, I think, like you said, there may be changes in biology making that previously radiosensitive tumor more radioresistant, and that may be why it recurred. It may be that the edges of that tumor didn't get an effective dose, and so there's a couple of reasons why that might have recurred. and so I think we're always much more aggressive with the recurrences, trying to get the control, local control there, which makes us much more aggressive from a surgical side as well. Now, obviously, that all you have to take into account the patient's whole the milieu that you're in terms of where they are in their disease process, how many mets do they have, are they, how many rounds of chemotherapy have they had, do they have widely metastatic disease, or are we talking about oligometastatic disease? All of those play a role in deciding, is surgery an appropriate intervention or adjunct in this patient's care, which is why we have a multidisciplinary tumor board. Sam and I and a lot of other folks, including you, Mo, are obviously on the tumor board every week, and we discuss these patients at length, getting input from all of our colleagues to try to figure out what the best plan is for this patient. But I do think we are a lot more aggressive now for recurrent Mets and with surgery as well as radiosurgery than we were in the past, where it was just palliative radiation, really, for the most part, 20 years ago.
Dr. Chow did mention that radiation or SBRT for recurrent Mets is now being paired with immunomodulators. So how do both the radiation and these newer medications are playing into the role for when to stop them for your surgery?
Well, that's a good question. I think a lot of these are really new and we don't have great data on them. We try to time it so that for conventional chemotherapy that we're at the nadir of the cycle so that they have as good an immune response as possible and maybe even delay the next round. With immunotherapies, we've been, in many cases, just continuing them through the course, even through surgery, and had reasonable success with that. So I think it is a little bit left to be seen where these newer therapies are going to fall into in terms of how do we manage them perioperatively, because I think that's a bit of an unknown out there.
So you're saying that we're continuing the immunomodulators. At what point do you consider or how far out from surgery are you okay to restart SBR or to start SBRT for recurrent Met?
So recurrent Met's a little bit different than primary because they've had prior radiation. It also depends on what their first round of radiation consisted of. If they had conventional radiation, that's a much higher dose to the skin of radiation, and maybe makes it a higher risk for the skin not healing. So I'm a little more careful about how long we wait before radiosurgery, maybe 4 to 6 weeks. With primary radiosurgery, the skin dose is not nearly as high. So with recurrent radiosurgery, we're a little more aggressive, probably in the 2 to 3 week range. We've done as soon as 2 or 3 weeks, but typically it usually ends up being in that 3 to 4 week range by the time all the planning gets done.
That's very interesting. So it's important to know what was the initial type of radiation delivered. So in making that decision of how far out from surgery can we consider repeat radiation to the spine. To that end, when we're talking about incision healing, when are we involving our plastic surgery colleagues?
Well, I think that's a patient-to-patient decision, but I think that most of us are trying to move away from big, large incisions. And if we do need to have a big, large incision, getting plastic surgery involved. So doing MIS fixation, if possible, trying to minimize the incision size and minimize muscle disruption is really kind of where we've been moving to. In the cases where we do need to use a bigger incision, I've been involving plastics right up front with those recurrent tumors, just because we know they have prior radiation. We're probably going to have some wound healing complications. And in many cases, we're doing kind of muscle flap closures with those, not free flaps, but local rotation flaps to get those areas closed.
Okay. And so it sounds like the plastic closure for a larger incision is even more important if a patient's had prior EBRT in the past.
Correct. I think Dr. Shuba had a comment. He's raising his hand over there.
Please.
Yeah, I'm sorry, and thank you. This is so helpful for me, and I just wanted to get a sense for both myself, and if I'm thinking this, I'm sure other people are. Dr. Shao made a comment, and I wanted him to expand upon it, and then I wanted all the speakers to comment on this. So one was, I heard something about if you've had radiation in the last 6 months. So as a result, as a surgeon, I'm sitting there thinking to myself, we've got to give a separation or removal of tumor plus radiation that is durable, hopefully for 6 months, because it may handcuff the radiation oncologist. And I just wanted to see if that's first question is that true? In other words, you don't want to find yourself not taking a lot of tumor out or not giving it a strong dose so that you're back there in 2 months and being a problem. And the second question I would have similarly is I always learned that or maybe I never went through training in radiation oncology, but I always got the sense that the radiation oncologists did as high a dose as they could safely, given the constraints of the local tissues. And to me, even with a focused radiation, some kind of image modulated type conformal radiation, is there a maximum dose to some of those tissues, or does that wear off at a certain time? In other words, people say, hey, the cord already got some dose there, and so we're maxed. Or is it a time thing where that washes away over time? And those two questions, I think, are really beneficial to surgeons who don't understand the windows that we should work with the radiation oncologists on.
Those are great questions. The issue is always about cord recovery, right? We don't want to give radiation too soon where the cord hasn't adequately recovered. They've done pretty elegant pig experiments where they've done re-irradiation and looking at different time frames where they do the re-irradiation. And for some odd reason, around 6 months, a year, most of the radiation kind of washes out in a sense, right? The cord recovers adequately biologically, that you can feel a little bit more comfortable about doing more radiation. And so, just as a kind of a general guideline, as a rule of thumb for radiosurgery, we always like to give at least 6 months before we do more radiation to allow for maximal cord recovery. It doesn't mean that you can't do it earlier, but you're going to start to increase the risk of causing something like cord myelopathy just because of inadequate cord recovery. But it does also bring up the good question that, we don't want to necessarily just toss, for radio-resistant disease that's really impinging on the spinal cord, just tossing radiation, like conventional radiation where you're not really going to get enough to control it, and then find yourself in the back end trying to recover the patient with separation surgery, and then trying to figure out when you're going to be able to do the radiosurgery. Surgery does buy a little bit of time because you still have that time that you need to have the wound recover, so on and so forth. But it can really certainly be messy if just someone just tosses radiation just for the sake of tossing radiation. You really have to give a lot of thought, particularly for patients who have cord compression or cord abutment of disease, and something that may be difficult to control.
Thank you.
Sam, as a kind of a follow-up to that, I was going to ask, is there a maximum lifetime dose that the cord can receive?
Yeah, I mean, I think, we kind of sometimes have pushed the limit. So like, for example, when we think about patients who've gotten a lot of radiation, they may have external beam radiation. They may recur a year later, and then we do radiosurgery, and then they recur a year later after that, and then we do 30 gray and 4 fractions coming out from the Sunnybrook paper. And then they come back again and with recurrence, and then you're like, okay, now what do we do? And it might not be something that the patient may not be eligible for surgery for X, Y, and Z reasons. We've actually put out or in the process of putting out a manuscript looking at repeat radiosurgery. So this is the 3rd time around, but I'm going to tell you that that's pretty few and far between, and I think it's probably fairly risky in terms of causing cord myelopathy. But we've done it, and so it doesn't mean that it can't be done, but certainly poses that question: can it be done safely?
Dr. Chow, if I might ask, what do you quote your patients the risk of fracture associated with stereotactic radiosurgery? I know it varies depending if you have lytic disease and how much vertebral body is involved, but how much of an issue is that?
It is somewhat of an issue. So typically speaking, just right off the bat, patients never receive radiation to that area. The typical risk is about 10 to 15%. Obviously, patient has lytic disease is going to be higher. Patient has osteoblastic disease is going to be a little bit lower. But that 10 to 50% range is fairly accurate. It also depends on the radiation dose. So for example, Memorial Sloan Kettering likes to give a dose of 24 gray in a single fraction. They can do that safely because they have spine surgeons that will go ahead and stabilize the spine if they ever run into fractures. But that being said, their fracture risk is going to be upwards of about 40%. So dose of radiosurgery does play a part in terms of increasing the risk of fractures.
I see.
In the chat box, we have Craig Winkiss, who's asking, how does the material choice, titanium versus carbon fiber of the hardware, play a role in re-radiation where separation surgery is a component of the patient pathway?
So if I had my vote, certainly I would love everyone to have carbon fiber. But because it's easy to see. The problem with titanium is like when we do planning for spine stereotactic radiosurgery, we need to get an MRI scan. And you can imagine if there's a lot of artifact from the spine components, it could be difficult to adequately contour the spinal cord and the tumor as a consequence of all of that. So certainly carbon fiber makes it a lot easier. I mean, not everyone's going to be a candidate for carbon fiber. Carbon fiber is, fairly expensive too. If it's an urgent situation, that might not be something that's easily doable. So, in that situation, then we certainly think about doing CT myelograms, to help out with planning. Ajit, thoughts on that?
Yeah, I mean, I think that's something we've discussed a lot in our tumor board. I think the carbon fiber definitely has advantages with the imaging, and so I've been using that a lot more recently lately, just to help our radiation colleagues a lot with the planning. There are some benefits to it with follow-up imaging as well. It's a little easier to see recurrences earlier if it's near the pedicle or near where the hardware is. That being said, it's very expensive, and so it's definitely something to think about when you're putting it in, especially if you have long segment fixation. We've been playing around with more hybrid constructs using titanium further away from where the met is and carbon fiber closer to the met, as a way of reducing costs while still trying to glean the benefits of the carbon fiber instrumentation. But I do think that we're noticing some benefits in terms of targeting and as well as following the tumor longer term for recurrence.
The imaging makes a lot of sense to me. I wonder, Dr. Chow, if you could mention or if you could discuss a bit about the actual delivery of the radiation. There's been papers written and people have discussed the fact that it can actually interfere with the delivery of radiation. Do you find that to be an issue, or is it really mostly the imaging and planning?
It can be an issue. The accuracy could be influenced by scatter effect because of the titanium. I think in that situation, certainly you want to use your best planning system. So, for example, there are different ways and different uh, programs that we use for radiation planning. Some of them are probably less accurate. So, like pencil beam scanning, pencil beam actually planning is actually not as accurate as maybe something like CC convolution. So I know I'm talking about technical terms, but the physicists plan using different tools, and depending on which tool they use, certainly it could be even more inaccurate if they use more of a simple tool.
All right. If there are no other further questions, I wanted to thank my co-panelists, Dr. Dan Schuba and Dr. Joe Schwab, for joining us today and help moderate this session. And I'd like to give a very special thank you to our discussants, there, Dr. Ajit Krishnani and Dr. Samuel Chow, for a really insightful conversation. Thank you both for your time.
Thank you.
Thanks for having us.